Good afternoon, and thank you for joining PQA for today's Quality Forum webinar. My name is Richard Schmitz. I am PQA's Senior Director of Communications and moderator for today's discussion on medication access, leveraging quality measurement to address social determinants of health. Before we get started, I want to remind everyone of PQA's upcoming annual meeting. It takes place May 15th through the 17th in Baltimore. The early bird registration deadline is April 15th. Everything you need to know, including the meeting agenda, registration and hotel details, and exhibiting and sponsorship opportunities is on the PQA website. We hope you'll join us in Baltimore in May. A few quick reminders as we begin today's presentation. Please submit your questions for our speakers using the questions feature located on the webinar control panel. At the end of today's presentation, we'll cover as many questions as time permits. This forum is being recorded. A copy of the presentation, the slides, and the recording will be available through the member portal of PQA's website next week. We also have a brief survey for you at the end of today's webinar. We're particularly interested in your ideas for future webinars. I would now like to introduce today's presenters. First is Matt Pickering. He is PQA's Senior Director of Research and Quality Strategies. He identifies needed studies to further validate the impact of PQA's measures on improving patient care, reducing overall healthcare spending, and filling recognized gaps in performance measurement. He's joined by Lee Holland, who is PQA's inaugural research fellow. She recently received her PharmD MPH from East Tennessee State University. While completing her education, Lee was active in several projects to create and improve student support services, including in creating an innovative IPPE program. Before we hand things over to Lee to begin today's presentation, I would like to introduce Kimberly Westrich, Vice President for Health Services Research for the National Pharmaceutical Council. She is responsible for leading research initiatives on the value of pharmaceuticals. The framework that Matt and Lee will present today was made possible through support from NPC. PQA is grateful for NPC's support of this important work. Kimberly?
Thank you, Richard. We are so pleased to have been able to provide the support for this research. For those of you who don't know NPC, we are a health policy research organization here in Washington, D.C., and we focus specifically on the role and value of biopharmaceuticals in improving patient health. We do that through a variety of channels. We conduct research like Matt and Lee are going to tell you about today. We host and sponsor educational events, and we collaborate with partners like PQA. So why did we support this research? I think it's no secret to anybody on the phone that the barriers to medication access and barriers to compliance have long been a serious problem here in the U.S. for our healthcare system, and they can cost billions of dollars when you look at all of the opportunity costs, the lost productivity, extra doctor visits that may be needed, hospitalizations that were preventable, nursing home admissions, and sometimes even death. We believe that quality measures can impact the barriers that patients face in medication access and help offset some of these costs. So the framework that we're going to learn about today really gives some actionable steps to begin to break down those barriers to care. And with that, I will turn it over to Lee to talk about the conceptual framework that we helped develop and describe the patient's medication access journey and how quality measurement can fit in. Lee?
Thank you, Kimberly. Diving right in, access to care development of a medication access framework for quality measurement. The reason why PQA was interested in this work is that the organization was founded in 2006 in response to Medicare Part D going live to help create quality measures to use in that space. PQA has several adherence measures that have been developed for use in various programs. And so that's one of the reasons why we were interested in exploring medication access and some of the underlying issues that might be impacting adherence. This project started in September of 2017, and I consider myself very lucky that I was able to start working on this project first as a pharmacy student doing an API rotation. Later on, I continued working with PQA as part of my Master's in Public Health field research, and then continued this work as a PQA research fellow. Okay, I think everybody who's taken part in this webinar realizes that there's a lot of challenges for patients in accessing medication. Some of the issues around medication access include complications for patients, including increased morbidity, mortality, and reduced quality of life, increased utilization of healthcare services, including emergency department visits and hospitalization. All of this increased utilization of healthcare services due to lack of access to medication significantly increases healthcare cost. It's estimated that over $300 billion in additional healthcare costs each year are generated due to a lack of patient access to medications. Now, a lot of things have been done to try to help increase patient access to both medication and healthcare. The Affordable Care Act is one of the first things that comes to mind. And it helped increase access to healthcare in the United States by a variety of mechanisms. First was the Medicaid expansion in some states, the creation of healthcare exchanges where people who couldn't get insurance through employer-sponsored health plans could go ahead and purchase healthcare or healthcare coverage directly. Increased coverage for young adults on their parents' health plans, enabling people to stay on their parents' health care until age 26, and also the elimination of pre-existing conditions on most policies. Healthcare access here in the United States is still something, however, that we are still struggling with despite the enactment of the ACA and other policies and programs trying to increase access. Taking a look here, this is a list of industrialized nations or developed nations that the Commonwealth Fund took a look at in a study. And unfortunately, when it comes to access to care, the United States comes in last among the nations that they were taking a look at. Now, one of the access issues, of course, is affordability. Affordability as a barrier to medication use and also as a barrier to health care in general. Now, among insured Americans, it's estimated that 14% report that they underuse medication due to cost. This underuse means either not filling prescriptions or not taking medications as directed, trying to stretch out their medication to last as long as possible. Among uninsured Americans, issues of medication underuse are even more severe, with estimated 33% of Americans who don't have medical insurance underusing medication. So our next question really needs to be, what's going on behind this? Because there's some serious inequities going on as far as access to medication and access to care. Equity here in the United States is another issue that we struggle with. Taking a look at the same Commonwealth Fund study that we looked at previously, equity here in the United States, we also come in last place in taking a look at developed nations and equal access to health care. Kind of digging into this a little bit, this was a great study that was done by the Kaiser Family Foundation, taking a look at healthcare equity. Now, this particular study took a look at patients who delayed care in the past 12 months, and this is among working age Americans. Taking a look here, you can see that there were definite disparities in reasons why people were not getting care because of cost. All of the percentages in this particular graph that have a star next to them indicates statistically significant differences from the white population. Now, taking a look at reasons other than cost why people delayed care, you can take a look and you can see that the disparities are even more stark. So there's more going on here than just cost as an accessibility issue. Now, one of those things to take a look at is the social determinants of health. The previous slide we were taking a look at broke down access based on race and ethnicity. So we know there's something going on besides just the cost of access to medication. So now we need to take a look at the social determinants of health. A lot of the social determinants take a look at things like economic stability, neighborhood and physical environment, education, food, community and social context, and local healthcare systems. Basically, the social determinants of health are about what circumstances or physical environment a person is born into, they grow up in, they work in. So basically, the environment that somebody lives in can have a major impact on their health outcomes. Some of the reasons why people might have issues accessing the care other than cost are listed out here on the slide, taking a look at the social determinants. Things like income, employment, maybe somebody can't get time off work to go to a doctor's office visit. Transportation, might be able to afford to see a doctor or go to the pharmacy and pick up medication, but they may not have transportation. There's also other issues, like provider availability. Are there doctors available for them to be able to see within their communities? All of these social determinants of health have a major impact on outcomes, including mortality, morbidity, life expectancy, and how much people pay on health care. Now we're going to take a look at the impact of different factors on risk of premature death. Now, this particular study, also done by the Kaiser Family Foundation, says that approximately 20% of that comes from the social determinants of health. And approximately 40% comes from individual behavior. The question that we need to start asking ourselves is, how do the social determinants of health impact individual behavior and individual choices that people may have when it comes to their health care? One example might be if healthy food is available. We all know diet has a major impact on health outcomes. It might be a situation where somebody goes to the grocery store and a loaf of white bread is only $1, but healthier whole grain options can be 2 or 3 times that much. So we need to really start taking a look at how the social determinants of health and individual behavior interact when it comes to health care. Now, everybody knows right now there's a lot of changes going on in the healthcare landscape. One of the biggest ones is the shift from volume to value. Now, quality measurement is a major aspect of this shift because in going from volume to value, we need to be sure that quality care is being delivered to patients. A lot of stakeholders are focusing in on the social determinants of health to help improve patient outcomes and improve their scores on quality measurements. So as a result, quality measures are one possible lever to address system-wide medication access issues. Now, we're certainly not saying that quality measures can solve all social determinants of health issues, but it is one tool that we have that we can look at and try to see what we can do to help patients. Now, there are a lot of adherence measures that are in the quality measure landscape, but we really need to start thinking about moving beyond medication adherence, because adherence is just an indicator for patients who already have access to health care. It doesn't give us any information about why a patient is non-adherent. It only works for those that already have health care, and it doesn't address any of the social determinants of health. So that kind of is the background behind this particular project. The objectives for the Access to Care project included convening a multi-stakeholder roundtable, developing a conceptual framework around medication access, and identifying priority gaps for future quality measure development, specifically around access to medications. Now, the Access to Care project was really broken into 2 phases. The first phase was a series of reviews to inform the second phase, and the second phase is where we brought together the multi-stakeholder roundtable to develop this conceptual framework. In review 1, we were really taking a look at barriers to medication access. Barriers to medication access were basically broken down into 3 major types: patient characteristics, healthcare system and organizational barriers, and then also environmental barriers. Out of that, we identified 17 of the most common barriers to access to healthcare. Review 2 was an environmental scan of existing access to care performance measures that are already out in the market, and many of these addressed adherence issues. The third review was taking a look at interventions to improve medication access, and there wasn't really a lot in that space, so there's might be some potential gaps there. All of this was pulled together to help inform the roundtable, to help put together a conceptual framework for informing medication access quality measures. The Access to Care Roundtable was a multi-stakeholder group. It was drawn from both public and private sector organizations, and it included major insurers, CMS, patient advocacy organizations, And the objectives were to develop this conceptual framework and also to define points in the healthcare system where barriers to access to occur, called nodes, and then develop recommendations for using this framework. I'd like to take just a moment here to acknowledge our roundtable. We had a great group that came together that really gave us some wonderful insights into barriers to patient access. It included nurses, doctors, pharmacists, certified pharmacy technicians, social workers, and public health and other healthcare researchers. They really put a lot of time and shared their expertise with us in helping put together the framework. And this is the Medication Access Patient Journey Framework. Now, it's holistic in nature because basically we wanted to take a look at everything that a patient had to go through in order to access medication. It's also cyclic in nature. It consists of 7 nodes. Each one of these nodes builds on previous nodes in the framework. A disruption at any one of these nodes may mean the experience would have difficulty in accessing medication. Now, it's important to note that while technically the last node is adherence, that doesn't mean that that's the end of the patient journey. There may be situations where a patient needs to go through this whole cycle several times. They might have a chronic condition where they need to get refills and see doctors. There might be a situation where a patient has an adverse drug event, so they have a perceived need to go back and get another medication to improve their medical condition. The first node is perceived need. That's basically where a patient becomes aware of an illness or a condition that they say, hey, I need to have this looked at, I need care. Once they have that perceived need, the next node that they move to is help seeking. This is where the patient is seeking to make contact with the healthcare system. They're trying to schedule an appointment with a medical provider. They might be reaching out to their medical insurance for a list of in-network providers, or seeing what their coverage is to see if specific types of treatments or specific disease states are covered. After help seeking, a patient moves to encounter. This is where the patient actually interacts with a healthcare provider. This is where they present their healthcare concerns for evaluation by a medical provider for possible treatment. Once the patient has the encounter, the next node is prescribing. This is where a medical provider selects a clinically appropriate medication after the assessment for the patient. And encounter and prescribing are of course, very closely linked. And one thing that I really want to stress is that with the encounter, it's not just a situation where a patient is having just any point of contact with the healthcare system or a provider. We want to be sure that they have a high-quality encounter with the healthcare system, including appropriate referrals for the patient. So the patient can be sure that they're getting the correct medication. Moving on from prescribing is prescription adjudication. This is a process of paying or denying a submitted claim for medication. It also includes medication utilization tools such as prior authorization and step therapy that might at times disrupt the timeliness of the patient receiving the medication. The next node would be prescription dispensing. This is the point of contact between the patient and the pharmacy where they're actually receiving the medication. And it's very important that for a successful dispensing, it's not just the patient receiving the medication. It's also that the patient is appropriately counseled on how to take their medication. For instance, if you have a patient that needs to use inhalers for asthma or COPD, a successful dispensing in that case would be the pharmacist being certain that the patient understood how to use those inhalers. The final node is adherence. That's where a patient follows a healthcare provider's recommendation to take medications as prescribed. And of course, once again, just because this is the last node in the patient journey, that doesn't mean that the patient doesn't need to continue on and go through several different cycles to be sure that they're maintaining whatever healthcare treatment that they need. Now I'm going to give everybody a moment just to get oriented to this slide. One thing that we did is we went to our roundtable members and we gave them the list of the 17 barriers that we had identified. And we asked them to basically rank barriers and where they thought that they occurred for patients as they were moving through the different nodes on the medication access journey. Now, this is not an exhaustive list of the barriers that we identified. These are the ones that our roundtable just identified as being some of the most common barriers that patients face. The first one I want to take a look at is health literacy. Health literacy was considered to be a major barrier across 5 of the 7 nodes. Health literacy impacts things like perceived need. Does the patient realize that they have a medical condition, and do they realize that there's treatment available for it? Now, when we defined health literacy, it just wasn't about a patient's knowledge of their own health. It also included the patient's ability to navigate the healthcare system and being sure that they have the knowledge to set up an appointment, or they knew how to contact their health insurance in order to get the information that they needed to receive treatment. Also, another major barrier that our roundtable identified for patients was cost. And cost doesn't just encompass copays or what the patient is paying out of pocket to receive health care. It's also about indirect cost, things like taking time off work to go see a doctor. It includes transportation cost, the cost of health care, I'm sorry, not health care, but child care, if they need somebody to watch their children while they're trying to go to a doctor's appointment. And one thing that we began to see moving through a lot of these barriers is really how many of these barriers are social determinants of health themselves, taking a look at things like cost and being able to afford health care. And also a lot of these barriers, as well as the social determinants of health, they heavily intersect one another. Taking a look at insurance, insurance was also identified as a major barrier in several nodes by our roundtable. And insurance just isn't about whether or not the patient has medical coverage. It's also about the type of medical insurance they have. You know, if they have Medicaid, Medicare, if they have a commercial health plan. It also encompasses issues like utilization tools, like step therapy and prior authorizations. And that also touches back on the previous barrier we were looking at, which was cost, because the insurance oftentimes dictates how much a medication is going to cost for a patient. Next, taking a look at medical conditions. Medical conditions can also be a barrier for patients in accessing care. And an interesting intersection between two barriers that we saw was the issues between medical conditions sometimes and transportation. An example would be patients with epilepsy. Many patients with epilepsy can't drive. So as a result, they have transportation issues in trying to access health care and access medications. And finally, taking a look at health system issues, including providers' beliefs and competencies, availability of medical providers, and also organizational health literacy. Organizational health literacy is an interesting concept. That's how health literate entire organizations are. Organizational health literacy is about medical providers knowing how to best help patients with health literacy issues. And it's an organizational-wide concept because it includes everything from front desk receptionist, being able to help patients. It includes having social workers available. It also includes competent transitions of care for patients as they're moving, for instance, from being inpatient in a hospital into a home setting or being transferred to a skilled nursing facility. And all of these different points, especially those health system barriers, are potential places where maybe we can start taking a look at potential quality measures to target patient access to care. And with that, I'm going to go ahead and turn it over to Matt.
Okay. Well, thank you, Lee. So, and again, thinking about and just sort of highlighting what Lee has said is looking at those barriers in the framework. those barriers are areas with the roundtable input felt would be some opportunity for quality measurement, as well as some other areas for quality improvement activities in addition. And they provided some recommendations within this report as well, which is laid out in a little bit more detail, but we'll touch on them to discuss areas of focus and where to sort of begin. So next slide, please. So there were 9 total recommendations that the roundtable had developed for this report and this rubric, of which broke out into about 4 categories or 4 areas. One in the measure gap identification prioritization. And so we've sort of discussed this could be how you can look at the barriers within these nodes and think about ways you can try to do some quality improvement or even some measurement activities. The next one is around quality core measure set, which we'll touch on here in a little bit, but thinking about where we're thinking as a measure developer and also these value-based programs, thinking about core measure sets as a means of targeting certain disease conditions or high priority areas, of which I think access to care and specifically medication access could be one of a high priority area within the United States. And then patient and community engagement, and this is within quality measurement. So it's not just the patient and caregivers and advocacy organizations here, but it's also the community organizations as well. And this is speaking to the areas of social determinants of health and working with community organizations in a way to bring them into some quality measure development activities to better inform what could be feasible, as well as partnering with these organizations. And lastly is the role of pharmacy. The pharmacy is very much highly penetrated into various different communities that can be leveraged very uniquely and innovatively to try to get to patients being adherent, obviously, and also those aspects within the node of adherence and dispensing, but also targeting through certain programs, social determinants of health. Next slide, please. So going into some of this a little bit more in depth with those specific recommendations, again, those were the 4 categories I mentioned previously. Now we're going into the category of measure gap identification and the specifications within those, one of which was around cost. And we had, or Lee had talked about how cost should be viewed as both direct and indirect, where direct is the direct cost of the medication, like the out-of-pocket cost, but also the indirect cost around transportation issues or childcare or time off work, et cetera. But it's not to say that the roundtable did not say that costs should be specifically a focus within a quality measure. What instead is if you were to consider cost in some other aspects such as health literacy and patient counseling about a medication, really cost should be part of that discussion. Can the patient actually afford the medication before it's prescribed? What other potential options are there? And with indirect costs, if patients have difficulty getting to see a provider, obviously there could be different mechanisms or different ways that they could engage with the healthcare system to see a provider through different types of transportation vouchers, et cetera. So moving down, the use of the healthcare services or telehealth services. As we increasingly are seeing a lot more of telehealth services being utilized, this is a great way to be able to target patients who have these transportation issues as well. And also for patients who have language barriers and even cultural barriers, and reaching those communities in a way that you may not have been able to in the past. So NQF, the National Quality Forum, is also doing work in this space around telehealth services and measurement as well, recognizing that this is a way and a means to target certain populations and communities of social determinants of health. Lastly, on this slide, it's perceived need and help seeking. They have the most impact. So in addition to mapping these barriers across these different nodes, we also asked this roundtable to sort of, if they could rank where would the nodes be of most impact, and they ranked perceived need and help seeking to have the most impact on medication access. And it sort of makes sense. If a patient doesn't really understand their own condition or have that health literacy high enough to understand how to engage with the healthcare system, for example, they will not enter into further down into this framework. The caution here, though, is it's very difficult to do some measurement here. There are not a lot of standardized data sources like there are with claims. So adherence maybe have the most opportunity for further measure development, even though You could argue there's a lot of adherence measures out there already, but for the patient, the perceived need and help-seeking side, these are going to be more patient-reported outcomes or patient experiences types of development, which need to consider surveys and items that you can try to reach patients and also gather that information with a validated tool. Next slide. So some other recommendations within the measure gap identification and prioritization was to increase the focus on the nodes other than adherence. And we just sort of highlighted that, whereas adherence and quality measurement there has a lot of standardized validated data sources like administrative claims. So we know we can develop measures in that space. However, there are other opportunities outside of that, not just with perceived need and help seeking, which may be more difficult depending on what the patient population, but also within prescription adjudication and dispensing. So the two areas closer to adherence, and working with pharmacies and also health plans in a way to ensure that there's quicker turnaround time for certain medications, for example. And actually, PQA had launched a turnaround time task force to develop a measure that really tries to make sure that patients are getting specialty medications in a shorter amount of time. So we are definitely aligned with this recommendation, specifically around thinking about measures outside of just adherence, but also thinking about dispensing and even adjudication as well, which is again filling that claim. Next is assess the capacity of organizations to promote an environment that supports health literacy. So this is what we've touched on with this organizational health literacy, which is it's not enough that the patient needs to be health literate, but the providers in the health systems also have to have the capacity and best practices in place to ensure that they also are health literate, and this is also them understanding how to navigate the healthcare system as well, understanding different types of insurance options that could be available for patients during or medication options that are available to patients when they're getting a prescription, and Lee did a great job of summarizing that. The IOM, or the Institutes of Medicine, actually defined a series of attributes that really organizations should consider to try to move towards being very high health literate. And within those attributes, there are quality measures out there that exist currently that sort of hit all of those attributes, or a certain series of those attributes, of which we didn't include in this sort of environmental scan. But from this recommendation, there are measures out there that are starting to move towards ensuring that organizations and health systems are themselves health literate as well. And the last recommendation here for the measure gap and identification is to develop and implement a screening tool for medication access challenges. So similarly, with trying to get to patient-reported outcomes, there could be another tool that's developed to screen either within the physician's office or the prescriber's office, or even maybe with the pharmacy or some other area within that patient access journey, and where you're screening for medication challenges, such as these social determinants of health, so you can adequately make the appropriate intervention. And so this is an area of opportunity for potential researchers to think about developing and implementing this tool and testing it to be a validated tool to potentially be able to use for quality measure development. Next slide. So just touching on the remaining recommendations, there were really only one under the last remaining four categories here. And this quality measure core set, using and leveraging the framework and the nodes to think about developing measures across all of the framework, to be a core set that really goes after medication access and trying to target that. The roundtable did mention that the core set doesn't necessarily have to be measures that are used within quality programs or quality improvement programs like value-based programs, for example. There may be opportunity to have those measures within there, like adherence, for example, but the core set could also focus on just internal quality improvement types of considerations and indicators that would be helpful to sort of hit those barriers within those nodes, but still thinking about a quality measure core set that further aligns various different measures across different levels of the healthcare system, such as the health system level itself, or the pharmacy level, or even the patient level. And as we continue to shift from volume to value, we are seeing a lot more of this work through the National Quality Forum, through the Core Quality Measure Collaborative, various different disease states, and thinking about other high priority areas as well to develop quality core measure sets. So this framework could be that tool to help to inform where to start with a medication access core set. The second here on this slide, and again revisiting this patient and community engagement piece, really trying to develop measures that either address social determinants of health or issues that patients may be facing around medication access by bringing the patient and or community within the measure development process. So bringing them in all the way from measure conceptualization, so when you're generating the idea for a measure and carrying them through feasibility testing, even further testing, evaluation, use and uptake, and even maintenance. And actually in September of 2018, last year, PQA, in partnership with the National Health Council and the National Quality Forum, launched an initiative in which we are convening the patient community and other relevant stakeholders to develop a rubric that will try to assess meaningful patient engagement within quality measure development. So similar to a rubric that you would be using to get evaluated as you give a speech or you give a presentation like I am today, based on a series of criteria and levels of achievement within that, really informing, being informed by the patient community that we've convened for this effort to assess, again, how well measure developers are engaging the patient community and incorporating their input within quality measure development. So really taking that as an action for PQA as well, based on the work and the recommendations from this roundtable. And then lastly, of course, but not least, the role of pharmacy and the increased value that pharmacy is having within these various different quality improvement programs and different types of operation models that they are implementing within their own pharmacies and engaging with other stakeholders like health plans, health systems, et cetera. If you think about those models like the appointment-based model or others to improve vaccinations, or going out to community organizations to provide vaccinations, ways that pharmacy are engaging these patients, and then also can potentially screen for certain issues or provide referrals to certain community organizations or volunteer programs, for example, if there's social isolation going on with a potential with a patient. So the role of pharmacy is very much for PQA top of mind, and trying to continue to show how pharmacy has value within healthcare, but even more so how they can also have value within the area of social determinants of health. Next slide. So those were the recommendations, some of which PQA has already been acting on, but we do encourage those who read this report in depth and some of the more of the rationale that was built out for these recommendations, researchers, measure developers, and the like, really think about how they can engage in this space based on this multi-stakeholder input as well through those recommendations. There are limitations to this framework, obviously. As you've probably been seeing, it's very broad, and as far as the access issues, we do capture quite a few barriers, including those around social determinants of health within those. Some are very common across all of them through this multi-stakeholder roundtable input. And we didn't focus on any disease state specifically, nor any specific subpopulation. So there's just those things to consider. This was largely just broadly thinking about medication access without a specific focus on a disease state, which would change some of the considerations on where to focus on for certain barriers. Next slide. So for future directions, some of which we've sort of touched on with this work, wanting to continue to leverage this to think about how we can use it for measure development, potentially aligning with some of the nodes or the barriers within those nodes, but also the core set work I mentioned before, and thinking about how we can make a core set, not necessarily measures to be used in value-based programs, but maybe a mixture of the two, where you have some for quality improvement as indicators and some that are already used in medication or value-based programs like adherence, to really develop a core set that could help to ensure that patients are being engaged with the healthcare system. They're addressing some of these social determinants of health, and also ultimately leading to receiving the medication and potential adherence. And this, lastly, as we touched on, just sparked innovations in care delivery, and including the community pharmacy engagement, and this as well as pharmacy techs to address social determinants of health. And next slide, please. And in summary, so there are various barriers to accessing medications, and they do intersect, and they can be complex. We are seeing a lot of efforts by the healthcare community to try to target social determinants of health, provide opportunities for patients, whether it be food insecurity or even housing, to try to address those concerns and those socially unmet needs to improve care. And quality measures are just a way to sort of monitor that. And quality measures may be able to be used to leverage and target those areas as well. And from this shift from volume to value, there obviously are various different opportunities to improve access, some of which we sort of touched on today through those recommendations, and leveraging this quality measurement by targeting medication access beyond adherence and focusing more upstream through this framework and the barriers that exist within these nodes is an important consideration, because as we entered into this project, PQA has a lot of different adherence measures that are used within various different programs by various different stakeholders, but those that are not being adherent, it doesn't really tell us much of what's the underlying issues around that, what's going on upstream potentially that could be impacting their non-adherence. And so this framework was to help depict most of that and try to think about measurement to help support those issues. So with that, I think we can open it up for questions. Oh, go to the next slide, please. Oh, I'm sorry. One more slide. Where does this live? Exactly. So this lives on our PQA website. So you can go to pqaalliance.org. That's PQA and then the word alliance.org. And if you click on the research tab and go down to completed research, you will find this access to care project and a nice little picture of the front cover of the report, and you can access it there. And next slide. All right, now we're at the questions. So love to open it up for any questions.
All right. Well, thank you, Matt and Lee. That's a really great presentation, and sounds like the framework provides some exciting opportunities to improve medication access with the help of quality measurement. We do have a number of questions from the audience, so I will share those with you now, and we'll answer as many as we can. So the first question is, in the literature and in experience, adverse events to medications, sometimes what the health system considers minor, such as bad taste and often sedation, are frequent barriers to adherence. Was that discussed in the framework?
Yeah. The roundtable did discuss the adverse events specifically as should it be considered as its own separate node. But the roundtable more leaned on as a potential barrier to adherence, as we just heard, that is going to be within that adherence node itself. And so for this cyclic approach and how this sort of reconnects with perceived need, if that patient does have an adverse event taking a medication, for example, that will then sort of make them feel that they need to seek care to understand what's going on with the medications they're taking. But it was discussed. It was not included as a separate node, as it more so fit under as a barrier to adherence, but it also would be a perfect example of how if there is an adverse event, it would then lead and move the patient back to perceived need to go seek care to either get the medication switched or see what's going on.
So Matt, it's interesting how health literacy falls under adjudication of the prescription and not dispensing. Effective counseling is extremely tied to a patient's health literacy, not just organizational health literacy. Can you talk to that issue?
Effective counseling was what?
Effective counseling is extremely tied to a patient's health literacy, not just organizational health literacy.
Yeah. Lee, did you want to talk about that?
Yeah, counseling, one thing that we found in going ahead and especially during the environmental review of existing quality measures is there's a lot of counseling quality measures that exist specifically to help patients understand their condition and understand how to take their medication. Organizational health literacy is more the concept of health literacy with healthcare organizations and how they function. And so a lot of times I see that the organizational health literacy, being sure that the providers are health literate and they're educating their patients in health literacy, it kind of goes hand in hand because good organizational health literacy means that healthcare facility or organization is educating their patients in health literacy.
And within the prescription adjudication specifically, and we've mentioned this before, it's not just being health literate about the disease state or your condition. The health literacy that was also recommended through this roundtable was to consider how a patient or the degree of knowledge a patient has about their own health plan, their own coverage options, and their own different types of insurance design or providers covered it within that network. So that degree of knowledge as well within the health literacy component.
All right. Next question asks, what current data sets or resources exist around the identification of individuals of need regarding social determinants of health?
The identifications of the individuals of need?
Yeah, data sets or resources for identifying individuals of need.
Yeah, so it depends on how you're defining need and individuals of need. So if it's a patient actually saying that they need somebody who needs to seek care, those data sources were really going to be what you have from patient surveys or potential registry information around this. There is the NCBS, for example, which is the Medicare Current Beneficiary Survey, which goes on every year. It's a panel survey going on for 4 years. They actually have questions within there that gets around some medication or healthcare access issues. And so if you're thinking about needing to seek care or data to sort of capture that, depending on how you're defining need, but if it's something from the patient and patient needing to seek care, the surveys and databases that have those types of research databases, like I mentioned the NCBS, there are potentially others, would be some of those data sets, those survey components.
All right, next question. What standardized tools exist for healthcare institutions to collect data about SDH from their respective populations? So a little bit related to the issue of data, but kind of creating data. So tools to collect the information.
It's a great question. I'm not familiar with the number or breadth that could be out there, but as far as validated tools that you can implement to understand these types of issues, we talked about the medication screening tool that would also try to get at that. I don't know where this may exist, but there may be some tools that organizations are using for their own patients that currently exist or that they currently serve. But as far as a database of different types of tools for social determinants of health, I'm not familiar with where that could be. Yeah,
So in the framework, there's presented 7 nodes and multiple overlapping barriers. From the project and the roundtable's work and deliberations, do you have recommendations on where developers should start with this? Is there low-hanging fruit to be pursued?
Yeah. And this was one of the things we were trying to get at with asking the roundtable where the most impact could be and where the most opportunity for measure development. And it was flipped. And so when you're thinking about the most opportunity for measure development, adherence was the highest. And because we do have the standardized data sources to do that. But as far as where there's most impact was perceived need and also help seeking. Those areas would require more research into that space, would require more survey development and validation into that space, and then obviously could potentially be used in certain quality improvement programs. But when that question about, what is the most, could be the most immediate to go with outside of adherence was dispensing and prescription adjudication as areas where there are data sets even at the pharmacist level, at the pharmacy level as well, with dispensing data that could be, measures could be developed out of and utilized in different types of arrangements, as well as within adjudication and adjudication levels. We mentioned turnaround time. So those two, outside of just adherence, those 2 nodes were areas where the roundtable felt that those have the most opportunity, but the most impact still remaining on the perceived need and help-seeking side, but the difficulties and timelines that would obviously for developing those types of tools. But encouraging researchers to potentially look into that space and develop tools and validated tools that can be utilized for quality improvement programs was also mentioned.
All right. I think I have a question that's somewhat related to that. It might give you an opportunity to speak to that issue further. Last November, HHS announced that it was going to pursue some projects to allow Medicaid pilots to pay for food and housing. You know, does that initiative or similar efforts within that program, you know, present opportunities to implement some of the ideas in the framework?
I would say so. And I don't know if Lee has anything to comment on either, but yes, as these newer types of models to address these social determinants of health, whether it be food insecurity, which was not part of the framework, but other areas like CMS and announcing that health systems or hospitals could also pay for certain services for social determinants of health, and what we're seeing on the Medicare Advantage and even commercial sides as well, specifically UPMC paying for housing. So these health plans, whether it be Medicaid or Medicare, or even in the commercial sector, that are now moving forward into that space, allows this framework to further be utilized and implemented in some level, some way. It's a little too soon to sort of think about what the ROI might be on all of this, but within those programs, there needs to be some sort of measurement to see how well patients are improving, and whether the indicator be adherence as that indicator, that end indicator. It just depends, but yes, it does provide opportunities for this framework to be used and implemented into those new models.
Okay. Loneliness is a topic of particular press and professional literature at a recent PQA meeting. Did the roundtable discuss specifics as to how community practitioners can screen and subsequently connect patients with community-based organizations?
Go ahead.
I think that this is something that's touching on the concept of organizational health literacy, because if some of these facilities or some of these healthcare providers were screening patients for these, screening them for health literacy issues, they could also pick up on some of these things like loneliness, social isolation, and might be able to connect patients with social workers that could help with these sorts of situations.
Yeah. And the roundtable didn't focus on social isolation or loneliness specifically, even though it was mentioned in the PQA meeting. And what we saw, for those that didn't attend the PQA meeting, a gentleman from Humana had presented around how they're predicting, based on the data they have and other external data attributes, if patients may be lonely or be socially isolated. And then they're pushing information down to the pharmacy level, that they're Humana pharmacies, to have the pharmacist screen for certain issues that may be an indicator that this a patient that's being seen at the pharmacy is in social isolation. And then if they were, that pharmacy or pharmacist would be able to connect them through community programs. I think that was a very, very perfect example of that recommendation within the framework around engaging community pharmacies in new ways and novel ways to address social determinants of health, specifically social isolation, which was, I think, very, very novel.
Has patient access to technology, mobile phones, internet access, et cetera, and patient utilization of technology been evaluated as a barrier to care?
As a barrier? No. I mean, I don't think, at least in this framework, it wasn't mentioned, but it is a good point. Not having access to those types of technologies being available to you is definitely a barrier within this, for sure. It wasn't one of the top sort of considerations that the roundtable pointed to with all of this, but it is. I would agree that yes, that is a barrier that would be impact medication access. And like Lee had said, and I'll turn it over in a second, the list that you saw here in the framework is not exhaustive. There are others that we identified as well. And Lee, I don't know if you wanted to speak to anything.
Well, no, I just want to say thank you for that question, because specifically CMS has programs to help connect patients with technology, with cell phones and with internet access, because they need to have that kind of access to be able to gain information, receive reminders from their pharmacies about refills, and so that's a very valid point.
I have another question on tools and resources for this. Are there tools and resources for tracking the health outcomes and cost benefits of investing in social determinants care?
So it would depend on what sort of outcomes you would want to look at. if you're thinking about cost specifically, total cost of care or just other types of costs incurred of interest. Within health plans, they would be able to track the impact that these programs or these types of models around social determinants of health that they're doing has on total cost of care for patients. So there are ways, if you wanted to sort of implement a tool or implement some sort of a model to partner with maybe a plan of sorts to target those populations and then use their data to evaluate that impact. I'm not sure if that was addressing that question or not, but it was a good question.
Well, I'll just ask a follow-up. So, I mean, are you, and the research around this project, did the roundtable or the PQA staff encounter, any tracking or evaluation from, people in the field to measure whether or not activities to improve, care around these social determinants was actually leading to improved outcomes?
Yes.
and lower or justified expenditures?
So, Leon, you want to go?
Yes. Doing the literature review, a lot of really interesting programs and things came out of that. There's one specific program that waived co-payments for medications for cardiovascular patients, and that did have a very positive impact on outcomes for patients. So.
Well, no, I was going to say it's with these types of models for social determinants of health, one of the things that we weren't able to find is not really sure what the ROI is at this level. It's a little too soon to be able to understand what that ROI is. Even with that Humana study that I mentioned, they were just getting that off. They were just sort of having some preliminary data that they could show without any numbers. But it is a little too soon to tell. I think there's a lot of effort moving forward into this space and trying to address these issues. But as far as some of that immediate type of outcome, it's going to be a long game, I feel. These programs implemented into these communities, setting up the infrastructure, and then monitoring that to see that ROI is most likely going to be the long game from the investment that's put in.
Okay, well, we're nearing the top of the hour. I have time for a couple more questions. So if you have a question, please submit that now. Is there any discussion of reimbursing pharmacists for the types of screenings for SDOH you describe?
So the roundtable did bring this up. We did have community pharmacy representation or pharmacy representation within this. It definitely did come up, but it wasn't something that we included in this framework. It was a little outside of the focus for this, but in one of the recommendations and working with pharmacies, providing those types of services to where they can prove those outcomes for certain populations, I think would be of definite value to health plans, patients, et cetera. So those types of relationships and engagements were raised, but not a focus of this framework.
All right, so our last question, Matt. What is the next step for your research team and PQA in building on and implementing the framework?
Yeah. So right now, our next step is this core set idea. We've already been taking some actions with some of these recommendations. Like I mentioned, the patient engagement rubric that I mentioned. We also have this specialty turnaround time task force that would align well with the adjudication and dispensing nodes. But really kind of capitalizing on this recommendation of the core set work and trying to work with partners like NQF, the National Quality Forum, and aligning what they're doing with the Core Quality Measure Collaborative. And this is a high priority area, medication access and measurement, both either within value-based programs or quality improvement efforts can definitely be a start towards improving access to medications. So that for us is where we're trying to think about taking this to the next phase, as well as continuing to try to promote the value of pharmacy in various different ways and efforts that we do internally from other research projects. But the core set development work is an area of immediate next steps for us.
All right. Well, thank you, Matt. And thank you, Lee, for today's presentation. I also want to thank again Kimberly and NPC for their support of this project. As a final reminder, please do take note and advantage of the PQA annual meeting that's coming up. And we'd appreciate your feedback on today's webinar and suggestions for future topics. And you can take that survey, which will launch at the close of this webinar. So thank you again for joining us today, and goodbye.